both the first for an Indian ophthalmologist. It's a huge, huge honor that such a great personality, and he's so simple, he's so down to earth, he's so humble. You will never know how magnanimous he is, and still he has so many achievements to his credit. We are very, very indebted to him that he has come, and as secretary, on behalf of all the members of Bihar Ophthalmic Society, I express my deep gratitude to you, sir, for accepting our invitation. Thank you so much. Dr. Santosh Honavar, please.
Very elaborate introduction. This is as long as the oration. You cut into my time. Good afternoon. I'll be speaking about recent advances in orbital surgery and minimally invasive orbital surgery as part of Professor R.H.P. Sinha oration. It's a pleasure to introduce Professor R.H.P. Sinha. He was born in the Raj Parivar of Surajpur district, Sahabad in 1922, that is 102 years from now. Graduated from Patna Medical College in 1948. He was posted as additional lecturer in INDNT in 1948 and appointed as tutor. Went to UK in 1950 for higher studies, passed DO and DLO in 1952. That time ophthalmology and ENT were together as a specialty. So when he came back, he was appointed as a tutor in INDNT in 1954 and then became a lecturer and rose to become the professor of INDNT at IMCH Ranchi. Then he moved to Patna where he worked as a professor of ophthalmology, by which time ENT and ophthalmology had split themselves into two separate specialties, and then retired as principal and superintendent of Patna Medical College Hospital. He was the president of Bihar Ophthalmological Society way back in 1969-70 when most of us were not born. So that's his introduction, illustrious personality, Professor R.H.P. Sinha sir. I'll be speaking on the topic given. As you know, orbit is a Pandora's box, in the sense that when people talk about orbit, they talk about mystery and evil and the unpredictability of the tumors that come out of it. When you think that it is cavernous hemangioma, it turns out to be something else. When you think that it is a malignant tumor, it turns out to be benign. In such a complex situation, how do we achieve a balance of having life salvage, eye salvage, and vision salvage? So if you're a good surgeon, that is great, but you have to combine your surgical skills with some basic oncological principles, and with that you will be able to achieve all that. Specifically because more than 50% of orbital tumors happen to be malignant tumors. It's not the benign tumors that you deal with, in the sense that if your surgical skills are enough, that's good for benign tumors, but when you talk about malignancy, it involves life salvage as well. That's because precisely the primary goal of any management of any malignancy would be life salvage, and that is possible. A secondary goal would be eye salvage. You can sometimes sacrifice the eye in favor of life, and tertiary goal, if eye salvage is possible, is to optimize residual vision. You can never reverse the goals. So when you have a patient of orbital tumor in front of you, you have to ask these questions and answer yourself. What is it likely to be? Is it likely to be a well-circumscribed benign tumor? Do you think it's an infiltrative malignant tumor? Where is it located? Right in the orbit, or is it extending to paranasal sinuses or cavernous sinus or any other structure? What are its relationships? Is it related to any of the extraocular muscles that are critical for the movement of the eye, or optic nerve? Is it operable at all? Or do I deal with it in terms of medical treatment with just a simple biopsy? What approach would I take if I have to operate? And what do you finally expect? Do I expect life salvage, eye salvage, and vision salvage? All these questions the patients also have, and you have to go through this checklist to answer each of these questions and counsel your patients appropriately. So to go through a very critical, logical, stepwise approach, a clinico-radiological correlation, all this before surgery, and at the end of it, there are certain situations where you say absolute no to surgery. There are certain situations where you would say an emphatic yes to surgery, and there are certain situations which are in the gray zone depending on your experience and the facilities available. You may want to treat them or you may not want to treat them. Now, these are some of the approaches to orbital tumors. Non-surgical, injectable. You might be wondering what are these non-surgical and injectable, and there are minimal excess surgical principles currently, and there is biopsy as well. Non-surgical approaches. Now this patient doesn't even look as if he has a tumor, right? Does he have proptosis? He doesn't have clinically evident proptosis. But he's an airline pilot, and the very fact that he has visited a temple before he came to the OPD means that he's worried about something, and he was failed in his recent medical exam because he had this intraconal orbital mass which is pressing on his optic nerve, causing visual field defect, which he was not aware of. He had difficulty in flying, he was sent for a medical exam, as he failed in the medical exam, and he has been grounded, and flying airplanes is the only job that he can handle. Now, it is a matter of fact that it is a cavernous hemangioma. There is no doubt about the diagnosis, and it is a surgeon's delight. Shahid would tell me that he would love to operate cavernous hemangioma, and so would Jayan. But would you want to deal with a cavernous hemangioma which is sitting right at the orbital apex, pressing on the superior orbital fissure and the optic nerve? The consequences are that the patient may end up with diplopia, which he doesn't have. He may lose vision. He only has a visual field defect. He's not lost vision. And how do you treat such a patient? Do you want to be a very aggressive surgeon and take out the tumor and be happy with it, or would you want to consider the entire clinical situation and do something else? Here we choose a stereotactic radiation, and you can see the reduction in tumor volume. Not completely gone, but you appreciate that it has reduced by about 40 to 50%, thus relieving compression over the optic nerve, and the patient has got back his visual field and is back to flying again. So these are some of the situations where you would consider radiation as opposed to surgery. And also this is from the literature where a small cavernous hemangioma was pressing over the optic nerve, resulting in near total visual field loss. Following surgery, visual field has returned to normal. This by gamma knife radiation with 2000 centigrade. So what is currently believed is that if a tumor were to be in the shape of a pear like this, pressing on the superior orbital fissure and optic nerve, you would want to consider an alternative modality such as radiation. So this is yet to sink in. Many of the surgeons still want to operate on these patients and end up with loss of vision. But when a patient has a clarity at the clear space at the orbital apex, then that would be safe to operate. There are other non-surgical approaches as well. These are called target therapy. Pembrolizumab is one of the medications which you can use for melanoma with orbital extension. That is from the literature. This is an elderly individual. This is again from the literature where epidermal growth factor receptor inhibitor erlotinib was used to treat a orbital squamous cell carcinoma. This patient has a large orbital squamous cell carcinoma. Right eye has wet ARMD, he can't see it. Left eye is the only eye with vision, and it has moved up, and his pupil is obscured because of the tumor that is in the inferior side. The patient had an ejection fraction of 20, obviously no surgery could be done, and he was salvaged mainly by this particular drug which is currently available in India, and if you have a clinical situation of this sort, you can definitely use it as opposed to surgery. That's medical management again. For basal cell carcinoma which are inoperable, again we have this particular medicine called Erivedge or Vismodegib, which can be used to temporize the clinical situation and regress the tumor. For lymphoma, of course, we don't use surgery at all. We simply do a biopsy, if at all, and treat these patients very effectively with medical treatment. So non-surgical approaches are definitely in vogue in orbital surgery. What about injections? This is not a tumor, but for a colobomatous cyst, the first thing that you do is aspirate the contents of the colobomatous cyst and see if there is any visual prognosis at all. If no visual prognosis, then you can sclerose this cyst by using ethanolamine oleate or any such sclerosing agent. Here ethanolamine oleate has been used successfully, and the child has been fitted with a custom ocular prosthesis. So we can give injections in terms of sclerosing agents. This is a young lady with orbital lymphangioma. She does not have any functional problem, but she is of a particular age where she wants cosmesis. She is not happy with the lower lid retraction and the proptosis that she has, and also recurrent subconjunctival hemorrhage because of a lymphangioma which is all around her optic nerve and the extraocular muscles. She comes for cosmesis, nothing else. She doesn't want anything else. Now, even if you go by the safe supratemporal approach here, you may end up with diplopia, which she doesn't have. You may end up disturbing the optic nerve. All this being there, you choose injection here, and this was picibanil. Bleomycin is definitely an alternative, but for an intraconal lesion where the optic nerve is surrounded by the tumor, picibanil is a safe alternative. And all that we did was couple of injection of picibanil, and you can see how nicely the orbital space has cleared up, and she has got the cosmesis that she always wanted. So this is again a form of injection in a tumor where the Diagnosis is confirmed by clinico-radiological correlation. You don't do a biopsy in such patients, you depend on a good MRI specialist and also your clinical acumen and also the history, without which it is impossible to diagnose this condition. Now for a macrocystic lymphangioma with sudden acute hemorrhage within the lesion called a chocolate cyst, you aspirate the contents of the cyst either with radiological guidance or without it and inject bleomycin, that is the drug of choice and with which these children dissolve very beautifully. This is one more example of bleomycin injection. This is an anterior lymphangioma again treated with bleomycin. So for venolymphatic malformations or lymphangiomas, we don't do surgery anymore, we treat them only with injections. Now this is a situation of a 10-year-old child who had chronic proptosis for about 9 to 12 months and he also had a pseudo fracture in his femur. So our clinical diagnosis was eosinophilic granuloma. Now with eosinophilic granuloma having involved the orbital roof, dura being involved, there is no scope for curating this lesion and causing CSF leak. Even if you were to operate on this patient, the child would need a cranioplastic reconstruction because his roof is involved. So in such a situation, we do a biopsy from a safe zone of a tumor, wait under anesthesia till the child's diagnosis is confirmed by a pathologist who takes about 15 minutes under frozen section to confirm the diagnosis that it is indeed eosinophilic granuloma. Then you inject just a 40 rupee drug, that is triamcinolone, right into the lesion under visualization. 3 months later, you can see bone being partially remodeled, and 6 months later, the bone is completely remodeled without any need for a major surgery. This was a 15-minute intervention that happened in this child with eosinophilic granuloma. You can see one more similar situation. This is again an injectable. Now for orbital lymphomas with posterior extension, this anterior component is easy to excise, but the posterior component, which is hugging the eye and going beyond the equator, surgery is not possible and you often dependent on radiation for these situations. Now we have an injectable, that is perilesional rituximab. The same rituximab that we give systemically can be injected into the orbit as a form of local target therapy to get rid of the residual in the orbit, thus avoiding radiation altogether in such patients. What about dermoid? Dermoid is a surgical disease. You always thought that it has to be excised, but for patients who specifically don't want any incision at all, how can you deal with this temporal dermoid without having a skin incision? You cannot approach it by a lid crease incision, so you have to have a skin cut. But this young lady is totally opposed to a skin cut. She doesn't want any scar on her face. In such specific situations, we can aspirate the contents of the dermoid after having determined that it has nearly fluid content. It does not have pultaceous content, which is impossible to aspirate. Once you aspirate the content, leave the needle inside in situ, and then we create a foam of sodium tetradecyl sulfate. This is how we create a foam. Foam means that we take 1 ml of sodium tetradecyl sulfate and make it into 5 cc. That means it is expanded in volume so that it fills the entire cavity of the dermoid and its surface is affected. The dermoid surface is affected so that there is deepithelialization, and the results are obvious here. The patient is gotten rid of her cosmetic problem without any surgical intervention. Next bit is about incisional biopsy. For suspected malignant tumors which are infiltrative, we perform incisional biopsy. Now, incisional biopsy is definitely a treatment of choice for infiltrative lesions where surgery or complete excision is not possible. The problem with incisional biopsy is that not all patients where you do incisional biopsy, you are able to get a definitive diagnosis, which means that your intervention has failed. If you cannot get a diagnosis in a given patient or get a wrong diagnosis, then your management obviously has to be different, and that will lead to a adverse situation. So to avoid that, we do what is called a minimal interventional biopsy, but from a representational area. Example is this child with rhabdomyosarcoma. I'm already telling you the diagnosis that it is rhabdomyosarcoma. In such patients, we do biopsy from the superficial, mid-zone, and a deep biopsy well past the epicenter of the lesion. For example, if the tumor is here, we know this is the epicenter of the tumor. We take a biopsy from the superficial, mid-zone, and the epicenter of the lesion, and all this is sent to the pathologist. So we have to go past the epicenter of the lesion. Just for an example illustration, let me show you what the superficial biopsy in this child showed. It showed inflammation and fibrosis, which is just a reaction of the tissue to a necrotic round cell tumor. The child had rhabdomyosarcoma, but the superficial zone only had inflammation and fibrosis. So extrapolate it to a clinical situation where the surgeon just does a superficial biopsy and does not go deeper than that, then you would have a wrong diagnosis. You would treat this child with steroids with very adverse outcome. Right? So deeper biopsy did show that the child had embryonal rhabdomyosarcoma. Now this is a situation where a patient has bilateral orbital mass and we can suspect any infiltrative tumor or an infection here. He also had a collapsed nasal bridge prompting the diagnosis of vaginous granulomatosis. When we did superficial biopsy, it showed inflammation and fibrosis. Deep biopsy showed granulomatous inflammation. So you could conclude here that it is vaginous granulomatosis possibly, but we did not stop there. We asked our pathologists to do special stains, and on GMS stain we could find that it is fungal granuloma. What if we had stopped here? We would have treated the patient with steroids and he had fungal granuloma, so we would definitely have adverse outcome. So you should not stop short of special stains. You should go one step beyond, and if at all you have a clinical suspicion that it could be fungal granuloma, you should get special stains done. So orbital biopsy has to be very specific, past the epicenter, and if at all you have any problem in localizing, you can always do a navigational surgery. Be right within the tumor when you do biopsy, thereby avoiding larger incisions and also taking specific tissue for diagnosis. When you talk about surgery itself, we generally talk about minimal excess surgery. Earlier, when I was a resident or a senior resident, we used to cut the bone before Dr. Bethiria came in to operate to remove the tumor. So bone cutting was a mandatory preparation part of any orbitotomy. Lateral bone cut was mandatory. Now, lateral bone cut is no longer done. This young lady has adenoid cystic carcinoma of the lacrimal gland, a large tumor. You can see how large it is. And all we did was just a skin incision and not a bone cut here. Right. Yeah, this is a short video that I'll show. Sorry. Right, superior rectus and lateral rectus are brittled, and that's the skin incision being made, subcutaneous dissection, periosteal dissection, and a septal dissection because it was extending anterior to the septum as well. We are separating it from the palpebral lobe of the lacrimal gland to which it was attached. The periosteum is being incised around the lesion, and wherever there's a fibrous tissue adhesion, we have to very gently separate. Now we notice that the lesion is actually bilobed. Lateral rectus is right in between the two lobes of this particular large lacrimal gland mass. We are dissecting it from all around, and when we have enough dissection, we check its ballotability. It is quite easily ballotable. It is able to prolapse out through the smaller incision that we have created. Then we apply a cryoprobe for definite anteroposterior traction, and then undress all the tissues very gently that are attached to the tumor without using any cutting with a spatula, and only when there is a fibrous band or a periosteal band would we use a bipolar cautery, or for a vascular pedicle we would use a bipolar cautery. Rest of the dissection is by very gentle separation and the tumor comes out. This was a large tumor without any orbital or a lateral bone cut. It could be removed. This helps in many ways. One is that it does not give the tumor access to the temporalis muscle, which is a very vascular structure. Even if there is a microscopic rupture of the capsule or a microscopic residual, then it has a barrier between the orbit and the temporal fossa. Second is that, of course, cosmetically the patient can be rehabilitated. Next set of incisions are transconjunctival incision. This child had orbital teratoma, which was extending both on the medial as well as the lateral side of the optic nerve, and the child had disc edema. That is the reason why you had to operate. Now, how do you visualize the optic nerve clearly and dissect the tumor away from the optic nerve in a situation where it is on both the sides of the optic nerve? This panoramic incision of the inferior fornix with a lateral canthotomy and inferior cantholysis gave us access to the lateral cystic component, and as we started dissecting, we could visualize the optic nerve. That is the optic nerve. That pearly white structure is the optic nerve, and that is the medial solid component, all of which could be excised right with the inferior conjunctival incision, and that was the groove through which optic nerve passed. That's the lateral cystic and the medial solid component. The child is free of disc edema now. The esotropy, of course, needs to be corrected, and everything is fine. This was a young lady who had an inferior intraconal mass, but she did not again want a skin scar. And here again we did transconjunctival orbitotomy. Surgery begins with a lateral canthotomy and inferior cantholysis. Following that, we make an inferior phonacial incision using a monopolar RF electrode to minimize bleeding. Then we use a lid spatula to ledge the inferior orbital margin. Readily expose the periosteum with minimal dissection. Make a periosteal incision and subperiosteal dissection until you visualize the apex of the inferior orbital fissure or the infraorbital nerve. Those are our stop points where we don't go anywhere beyond. And then the blood vessels which are passing through the bone, the perforating vessels, are cauterized to achieve hemostasis. Then we incise the periorbita in the quadrant where the tumor is located. Then we use orbital fat retractors to gently retract the fat, visualize the tumor, and dissect it to the extent of about 60 to 70% until it becomes ballotable. Then we apply a cryoprobe for anteroposterior traction and continue to dissect under visualization. And as the tumor comes out, very, very gently, you have to look at the posterior pole of the tumor for a feeder vessel, which is often there, which needs to be cauterized, otherwise it will retract into the orbit, bleeding, causing secondary hemorrhage. So that's the feeder vessel that is being cauterized. And now there is no bone cut. All that we need to close is the lateral canthal angle cut that we have made, lateral canthotomy, and a few incisions, sutures through the inferior fornix. And that's how a patient can look about 3 weeks post-operatively. And that's a similar situation. And this is again a neurolemoma removed by that fornicial incision. The last bit is about what after surgery. You cannot stop at surgery. Well, you have removed a tumor completely, but can you stop there? You have to go for a good histopathological diagnosis. In a solitary fibrous tumor kind of a situation where we know that the tumor is likely to come back just with surgery, if the tumor is aggressive, then you have to go for post-operative radiation. This SFT has been very well removed, but you can see that it was infiltrating the infraorbital nerve, and the nerve also has been removed. But then there is a microscopic residual for sure in such situations, so you have to go for adjuvant radiation, otherwise the patient is bound to recur. In situations where earlier we would do orbital exentration, now we have a chance of salvaging their eye as well as vision. This was a patient with rhabdomyosarcoma all along the inferior rectus muscle. Now conventionally we would remove the entire tumor to have very minimal orbital residual, thus improving the prognosis. But now unless we salvage his inferior rectus muscle, salvaging of his eye is no use, because he is going to have retractable strabismus, which is very difficult to correct even with transpositional procedures. Such a situation, we do what is called a muscle sparing surgery. So this particular wedge of tumor that was around the inferior rectus was left, that is what is left, and what was removed was the rest of the tumor. Rest of the treatment is by chemotherapy radiation, which is anyway required for rhabdomyosarcoma, thus the child is spared of strabismus. This is a situation where exentration was required, but surgery in a large tumor which is highly vascular is going to be dangerous for systemic health of the patient. So we reduce the tumor, shrink the tumor down before we do exentration. There we could do a lid sparing exentration with a custom orbital prosthesis. This was a patient with adenoid cystic carcinoma of the lacrimal gland, very well treated by the surgeon. The patient does not have any orbital recurrence at all, but several years later, patient presented with lung metastasis. That's because here is a great surgery, but systemic component was not taken care of. So in adenoid cystic carcinoma, we do use multimodal therapy, where we shrink the tumor and then do complete excision. Then we give radiation to the orbit, then give adjuvant chemotherapy as well. So with multimodal therapy, where we combine chemotherapy, surgery and radiation, you have much better success. Bone being involved in adenoid cystic carcinoma, earlier we would do exentration with orbitectomy. Now no longer so. Eye and vision can be spared, and the bone actually remodels. As you see again in this young child with adenoid cystic carcinoma, bone has completely remodeled. So this is the beauty of adjuvant therapy. Now this is a recurrent adenoid cystic carcinoma where radiation was already given, so we have facilities to give afterloaded interstitial brachytherapy with iridium, so we can selectively irradiate the bed of the tumor with much better outcome. Now, patients who are earlier exenterated no longer are exenterated. This is sebaceous gland carcinoma, where you can see a very good tumor reduction following chemotherapy. This is a gross example of reduction of sebaceous gland carcinoma with chemotherapy. This patient was destined to orbital exentration. Now after chemotherapy, all that is left is in the medial 2/3 of the lower eyelid, amenable to resection. This is a patient with a sebaceous gland carcinoma of the lacrimal sac, very unusual manifestation. One surgeon has done a DCR here, letting the cat out of the bag. Now it has intranasal extension as well. Patient has 20/20 N6 vision. He is absolutely against orbital exentration. There we again chemo reduced this patient, did dacrocystectomy, gives stereotactic radiation, and he is doing well 5 years later. In conclusion, I would say that orbital surgery, orbital tumor surgery starts with a very good logical evaluation of the orbit with a good clinico-radiological correlation, following which you decide exactly what form of treatment that you would like to give to a particular patient, counsel the patient and the parents and the family appropriately in detail, and then go ahead with treatment modalities. Currently, we have the advantage of using targeted therapy, injections into the orbit, doing a guided incisional biopsy, and also use multimodal technique. And if at all we were to do surgery, then we would use a minimal